Hello, thank you for joining. I'm Dr. Charles Taylor. I'm a junior doctor currently working at St George's Hospital in London, and today I'll be presenting the results of my study titled Improving Acute Delirium Assessments, a Quality Improvement Project for Care of the Elderly. Before I begin, I have no disclosures nor potential conflicts of interest to declare. As I'm sure you're all very much aware, delirium is a common and serious neurobehavioral syndrome characterized by acute changes in cognition and attention. The word delirium interestingly derives from the Latin for out and rut, D and lir, respectively, therefore loosely translating to getting out of the rut, and consequently representing that characteristic transient and reversible derangement of cerebral function that we know to be delirium. Descriptions of what we know to be classical delirium date back as far as to classical Greek times with reference to the work of Hippocrates. And the incidence of delirium among the older patient within the UK in the acute care setting is reported to be as high as around 80%. And research has also indicated mortalities between 22 and 76%. The aim of this study was to present a single centre experience of delirium assessments in the London Teaching Hospital Acute Senior Health Unit and to initiate a framework for future cycles to sustainably evaluate and enhance compliance to these NICE delirium guidelines. The research project was conducted as a mixed methods quality improvement study. Primary outcomes were the percentage of admissions with a full delirium assessment and the percentage with an attributed documented cause of delirium. Our initial two audit cycles were conducted as quantitative retrospective secondary analyses, and the intercycle interventions were designed following grounded theory thematic analysis, which identified three major barriers to guideline adherence: understanding the need, remembering to do so, and being held accountable to do the delirium assessments. Therefore, our interventions consisted of a one-off teaching session to explain the importance of assessments to staff, which addressed the understanding, visual reminders in the form of posters across the ward to address the remembering, and a dedicated tick box indicating completion of each assessment for each patient, thereby accounting for the accountability element. A chi-squared analysis was performed between cycles. So, with regards to the results, 52 patients were admitted to the Acute Senior Health Unit in July and 76 in September. Before our intervention, only 1.9% of patients, which was one patient, received a full medical delirium assessment, and only 5.8% of patients received a formal diagnosis. However, post-intervention, this increased to 56.6% and 27.6%, respectively. The chi-square test of independence was performed to evaluate the relationship between these formal delirium diagnoses before and after the intervention and demonstrated a statistically significant improvement. So, what do these results actually show? Well, they show statistically significantly increased adherence to national guidelines and evidence to support our low-cost ward-based initiative to improve adherence to delirium guidelines. We therefore propose this framework for future cycles and emphasize the importance of grounding any local interventions in both local and national barriers. However, more importantly, whilst it should remain a continual goal to better adhere to these national guidelines, the authors of this study suggest that the greater value is when we can consider the overarching impact of an increase in formal delirium diagnoses in general. The formal diagnosis that we've seen an increased number of patients receiving provides treatment clarity by distinguishing patient group by their shared set of characteristics, i.e. delirium. This helps to clarify the expected course and prognosis, as well as pointing towards possible etiologies and appropriate management strategies. With regards to future steps, I'm happy to report that we are currently in our fourth PDSA cycle, showing ever-improving results, and have an integrated clerking performer for our Acute Senior Health Unit in St George's now, which has a full delirium assessment for all patients admitted to the Senior Health Unit. Thank you very much. If you have any questions, I'll be happy to answer them either in the chat or live. Thank you.